Okay, we are going to be talking about local anesthesia, local complications. First thing I'm going to do is go over some definitions that we need to know for this section. A localized complication occurs in the region where you have given the injection. So it's attributed to the needle administration technique and or the drug, in this case the local anesthesia drug that's been administered. A systemic complication is attributed to the drug administered. A primary complication would be something like burning during injection. It's experienced at the time of injection. A primary complication, such as burning during injection, is also a localized complication occurring in that region where the injection is being given. A secondary complication would be something like soreness. It's apparent after the injection is complete. It's caused by the injection, but it's experienced later. A mild complication resolves without requiring treatment. So again, that burning on injection is a mild complication, which is a primary complication. So it's related to or experienced at the time of injection, and it's also localized complication. A more severe complication requires a plan of treatment to resolve the complication. So something like anaphylaxis, that is not going to be resolved unless there's immediate treatment and a drug intervention, probably an epinephrine 1,000 milligrams to take care of that anaphylaxis severe complication. A transient complication appears severe at the time, but resolves without any residual effect. So something like a hematoma, it looks really bad, looks very severe at the time, but in a 7 to 14 day time period, that hematoma is going to resolve and there's not going to be any lasting effect because of that hematoma. A more permanent complication would leave a residual effect. So it would be something like nerve damage associated with the inferior alveolar injection. That would be a permanent complication. So again, our list is localized versus systemic, primary versus secondary, primary being experienced at the time of injection, secondary experienced later, mild complication, no treatment, severe complication needs treatment, transient appears severe but it resolves with no residual effect, and a permanent complication would obviously have a permanent effect. One of the local complications that we need to be aware of, it's extremely rare, but needle breakage could occur. It could occur because of bending the needle. When I was an assistant, I would see the doctors bend the needle all the time, and I thought that was a normal thing. Got to hygiene school, realized that that is a reason for needle breakage, and of course I don't want any needle breakage, so no bending, and you don't either, so no bending the needle. If there is sudden direction change, either by you, maybe hand slips or something like that, or if the patient moves, that's more likely the case. The patient moves and that sudden direction change could cause needle breakage. If you were to force the needle, if you came in contact with bone and you were to try, or something hard, you know, maybe not even knowing that it's bone, if you came into contact with something and you tried to force past that, in this case, I think of the internal oblique ridge, when you know that you're very close and you're trying to force it past that internal oblique ridge on the way to the inferior alveolar injection site. So no forcing. Or if you injected the needle all the way to the hub. And remember, the weakest part of the needle is right where the needle meets the hub, right where it attaches and screws on. If we are using a 30 gauge needle, it's a smaller gauge, larger number, and that could also be a case where the needle could break, or a reason for the needle to break. We are always going to want to have some cotton pliers or hemostats with our syringe so that we can go, and if there was a breakage, we would have the patient stay open and we could retrieve it. If you couldn't retrieve it, it would be possible to leave the needle, and it would usually encase itself in scar tissue if it was small. If it was larger, we would have to obviously have them see a physician and potentially a surgeon, oral surgeon, to maybe remove that. We would note it in the record. We would inform the patient. We wouldn't want to try to hide this from the patient because they would know. They would know from my face, my eyes, but anyway, they would know, and we need to let them know. Anything that happens, we need to let them know, noted in the record, and inform an insurance carrier. Pain with injection can happen because of a careless technique, like you just inject too fast. Remember, for the IA, the inferior alveolar, we're talking about the injection lasting between 15 seconds and 60 seconds, 15 being the absolute minimum, and then 60 seconds would be more beneficial for the patient because it would be slower, it would diffuse slower, it wouldn't hurt them, it wouldn't go in rapidly and expand that tissue quickly. If you had a dull needle, there could be pain with injection. So maximum of 3 or 4 needle penetrations per needle. Needles with barbs. The needles can get barbs after contact with the bone, or they can have barbs just from manufacturing. Typically, the pain with a barb would be on the way out. As you're pulling out, it would be the little tip of the needle is bent just a teeny little bit, and the patient would feel it on the way out. Burning with injection can happen just because of the acidity of the anesthetic fluid. The pH of our tissues in our mouth is 7.4. The anesthetic with no vasoconstrictor, the pH is 5 to 6. And with vasoconstrictor, it's even more acidic. It is in the 3 to 5.5 pH range. So just the change in the acidity of the solution to the oral tissues. If the injection is too rapid, again, it can cause a burning. If there's any contamination of the anesthetic, if that anesthetic cartridge has been wiped, if that anesthetic cartridge has any contamination on the outside of it, and the temperature. We've talked before about how a warmer, a anesthetic cartridge warmer used to be used, and it was thought that if the anesthetic was closer to the patient temperature, then it would go in and it would be more comfortable for the patient, and that they have found that that is not the case, and that warmer temperature gives the patient a burning sensation upon injection. Now, paresthesia is the persistent anesthesia for many hours or days. The most common way that someone would get paresthesia is from trauma to the nerve. More often, it is with third molar extractions. It's associated with third molar extractions and trauma to the nerve because the third molar, the root or the root tip, is in contact or close to that mandibular nerve, that inferior alveolar nerve, and the damage is caused on the extraction of a third molar versus injection. There could be hemorrhaging around nerve. There could be edema that happens. I think I told you guys in class that after I got number 32 taken out, sensation came back, anesthetic wore off, sensation came back, and then as it swelled, it impinged on that nerve, and I lost sensation on that lower right for about 9 months. If there was any injection of contaminated solution, that could also cause paresthesia. So we really want to make sure that we have a sterile environment, we keep everything sterile and nothing is contaminated, because we're injecting this into someone. Problems with paresthesia, and I remember having this lower right numb for so long, is that if I could always kind of bite my lip, kind of catch my lip, and I always had just kind of a little sore spot because I would bite and not really feel it. And then it would, of course, swell a little bit. So I'd bite it and bite it and bite it because it was swollen. The patient could also lose some sense of taste with paresthesia. Most of the cases are going to resolve in 8 weeks. Once it goes over that 6-month time frame, one of my good friends is an oral surgeon, and she said she's amazed that I got feeling back at the 9-month, because usually if it's over 6 months, it may not come back. You need to speak to the patient personally about the fact that there could be paresthesia or the reasons for paresthesia. Reassure them that most cases resolve in 8 weeks. Explain the findings, have them come back in, keep checking up on them, possible refer to an oral surgeon, and you would want to avoid additional anesthetic in that area until paresthesia was resolved. Trismus. This is the spasm of muscles leading to a painful and limited jaw opening. Trismus treatment is going to be heat therapy, so warm compresses. Causes are trauma to the muscle or blood vessels, again, contaminated solutions, any hemorrhaging around the area of injection, multiple injections, especially if you're going and doing the IA and you've got to go through a lot of cheek. It's likely that that muscle and that tissue could get pretty sore. So maybe the next day the person has limited opening. Warm compresses in that area help a lot with regaining function. If you have a lot of solution, and this is another good reason for using the minimum amount of solution that we need, the anesthetic solution that we need to get the job done. If there's any infection in the area, if there's barbed needles, solutions that are myotoxic, so muscle toxic. And mild pain is common the day following an injection, and some of you after injections may have even had some soreness in the different areas, especially if we had to do more than one injection, or if we had to come out for any reason and then go back in. If the patient has difficulty opening, you can have them come back in and examine them. Heat therapy, hot moist towels to that affected side, warm saltwater rinses, analgesics, anti-inflammatory drug therapy helps a lot, and most cases resolve in just 2 or 3 days. Hematoma, this is a pretty major one in this picture. I told you guys in class about prom girl who we had done a filling on number 15 the morning of prom, Saturday morning of prom, and the dentist nicked something in the pterygoid plexus area, and she had, you know, bigger than a quarter size, maybe a 50-cent piece size hematoma on her cheek area. And it is a transient complication, appears severe at the time and resolves without treatment, but it resolves in 7 to 14 days. So she was not very happy to have to leave there and then go get ready for prom and have this hematoma on her cheek by, you know, on the left side cheek. It's not always preventable, but if you give an injection and if you aspirate well, and you aspirate the 3 times, and you have it at a 45-degree angle to the mid-sagittal plane and a 45-degree angle to the occlusal plane for the PSA, the posterior superior alveolar, then you are likely to not be in the pterygoid plexus area. The only reason I mention the PSA is because that is the most common injection for a hematoma resulting, or that a hematoma would result from. PSA is the number 1, IA is the number 2. Also, that mental area for the mandibular, the inferior alveolar is the most common, but then the mental is the second most common. You got to know where you're going. You can't just go in blind. You've got to know from patient to patient where your landmarks are. So this is so very important that you palpate and you don't just go in the same place on everybody. Hematomas are most common with the inferior alveolar and posterior superior alveolar nerve blocks. Use the appropriate needle length. So if you're using a short needle on the PSA and a long needle on the IA, and you're not going to move that needle around in the tissue, because if I poked you and moved something around, I would cause bleeding no matter where that is. If the swelling is immediate, apply pressure. Even when we're in the clinic and you guys do injections on each other, if there's any time when there's a little bit of bleeding on the withdrawal of the needle, we apply pressure to that site. If the swelling is immediate, if you see it immediately, apply pressure. Advise the patient to apply ice to the area. Heat will vasodilate the area and may increase the size of the hematoma. You would obviously want to tell them, and you would want to let them know that it's a transient. So the discoloration or that purpley hematoma would resolve in 7 to 14 days. Infection. You want to make sure that that needle and everything in regards to the injection is sterile. You don't want to, if you're dripping, we talked about this in class, if you have any drips coming off the bevel of the needle, the tip of the needle, you don't want to dab it on your gauze. You don't want to, wipe it anywhere. You want to properly handle needles, and you want to avoid multiple injections. 3 to 4 is the max with any one needle. For pain, because the needle will get dull. But you really want to think about if you were injecting into an area of infection or there was a lot of periodontal disease present and a lot of infection, you may want to change it even more frequently. You want to take care with those cartridges. You don't want to put cartridges on the tray that you're not going to use. If you didn't use them, they're contaminated. So people try to wipe them off with the disinfectant wipes, or they, in older days, or some offices might try to soak them. That can contaminate the cartridge, and then when the needle does go into that rubber stopper, it can have some disadvantages for the injection of that contaminated cartridge or previously contaminated cartridge. You want to wipe the area of penetration site to clear away the oral bacteria. So that's our topical wipe step. Edema or swelling. It can be because of trauma. It can be because of infection or because of an allergy. So you want to have a good technique for your injections. You want to properly handle all of the armamentarium that we are using for the injections. And you want to make sure that you do a thorough medical evaluation before treatment, and if there's any problems or allergic reaction, things that could occur, or the patient has any allergies. For example, if somebody mentioned that they were allergic to PABA, you would want to try to avoid esters. Or if they said they were allergic to Novocaine, you would want to avoid esters. Benzocaine is the most common topical, and it's an ester. It's an ester derivative. So you would want to potentially avoid benzocaine, maybe no topical, maybe a different kind of topical. So make sure that you know their medical history before you begin. Sloughing of tissues. We've talked about this a little bit. Epithelial desquamination is the same thing as sloughing. It's a possible reaction to topical anesthetic that was applied for too long, or if there was a sensitivity, or if you just had way too much of it. Remember I told you that people come out with gobs of topical on the cotton-tipped applicator. More is not better. More is going to potentially cause a reaction for your patient. And then a sterile abscess. This is secondary. It occurs with the vasoconstrictor, and it's most common on the hard palate. So here's the desquamination, or the sloughing of the tissues. Warm saltwater rinses are great in a case like that. And here's your sterile abscess. Here's the sterile abscess, typically on the hard palate. Local anesthesia with vasoconstrictor. Almost always happens in the hard palate, and 7 to 14 days later it would resolve. Soft tissue injury. This happens a lot with kids. They will get numb, and we obviously can't numb anyone under 18, but I've seen this as an assistant, and the child will get numbed for a filling, and they're numb to the midline, maybe, and they chew the heck out of their lip. I mean, it looks like hamburger because it kind of feels cool between your teeth. I know I've seen you guys in clinic kind of chew and kind of not really chew, but kind of just bite lightly on your lip, and it feels kind of cool. Kids think it feels really cool, so they will just chomp up and chew up their cheek. So you want to make sure that parents are informed if there's any anesthesia on children, because it will be asleep for a couple hours. Once they bite it, then it's in the way and they bite it more and more. So self-inflicted injuries, that is a self-inflicted injury. That can occur following the administration of local anesthesia. Advise the patient and or their parents about the length of anesthesia to expect and not to bite the lips or cheeks or tongue. Analgesics for pain, warm salt water rinse, and watch for infection if it does occur. Sometimes I've turned away and been writing notes up for the doctor, and by the time I've turned back, here's a kid who hasn't even left the dental chair that has already chomped down and has a soft tissue injury, self-inflicted. Facial nerve paralysis. This is all about technique, because the facial nerve goes through the parotid gland, and there's different places where the facial nerve is, cranial nerve 7. We are not anesthetizing the facial nerve. We're not getting anywhere near that. And with proper injection technique, we should not be getting any facial nerve paralysis as a complication. It innervates the muscles of facial expression, and some of the fibers can be infiltrated while administering local anesthesia. But us knowing where we're going and making sure that we are checking the anatomy on each patient and not just point and shoot. Any facial paralysis, we're reassuring the patient. Eye patch to the affected eye. I suppose if this happened, we would obviously record the incident in the patient record, and we would want to discuss whether the appointment should continue. Post-anesthetic intraoral lesions. Sometimes local anesthetic or just the manipulation of working in an area can cause a herpes simplex outbreak. So any manipulation can lead to the reactivation of a latent herpes virus. If patients are prone to getting cold sores, prone to having outbreaks, it can't really be prevented. I mean, we're doing what we need to do for the patient. We don't know if the patient is going to have an outbreak or not. We can mention that to the patient, but why bring something up? I mean, we can certainly advise what to do if it does happen and treat palliatively. You know, we wouldn't see them if they had an outbreak. We would have them reschedule so that we didn't spread it. Abscess ulcers will commonly occur caused by overreaction of the immune system, and we would treat this palliatively. Rinsanol is a rinse that's out there and that can diminish the pain with abscess ulcers. Also, warm salt water rinses. And typically we might know a patient frequently gets abscess ulcers, and we could discuss that with them. All right, great job, guys.